we all welcome to the first webinar after the summer break, and of course it's a great pleasure to introduce Axel Lucen again to present an exciting topic, and I hope he will be provocative. We will discuss following his talk in the panel, and I also respect Jean-Yves Play. He is also among us, and I want to extend this invitation to all everyone from the audience. So please give a sign through the tool that you have, whether you want to join, and then we hook you in so that we can all discuss. Otherwise, you can just ask the questions. I don't want to extend further. I am again excited to introduce you, Axel Lucen. I think everyone knows he's together with Jean-Yves the prominent exponents in sarcoma care, and we can learn so much from you. And I'm extremely proud that you again dedicate the time to share your experience with us. Please.
Hello, everyone. Do you see my slide here?
Yes.
Great. I'm very happy to see you again after this vacation. It's always a pleasure to meet you even virtually. I hope you are in good health after this rest period. I just want to share with you the different lessons we've learned from the large randomized trial in frontline chemotherapy in advanced soft-tissue sarcoma. It's a little bit provocative, but there is some important message I would like to give you in the field of sarcoma. I think you are all aware on this table, it is more or less all the randomized trial comparing doxorubicin alone versus combination polychemotherapy regimen with doxorubicin demonstrate absolutely no advantage for the combination comparing to doxorubicin alone in median overall survival. With a combination regimen, you increase the response rate. It is always good news for the patient, but unfortunately, without any translation for in overall survival. Here you have the last randomized trial coordinated by ERTC. It is the last randomized chemotherapy comparing doxorubicin versus doxo-E4 in non-selected histological subtype of sarcoma, and I think you are all aware on these results. There is a little advantage in progression-free survival, but no impact on overall survival. When you give a look in all these randomized trials and the characteristic of patient, including all these randomized trials, there is two categories of patient. Patient in totally palliative situation who represent around 80% of all patients. And there is some 20% of patients who can be cured by a combination of high-dose regimen followed by treatment of lung metastasis, I mean surgery, radiation therapy, stereotactic radiation therapy. So there is two different diseases. So I'm convinced if we include only patient in palliative situation, you can make all randomization between doxo versus combination. There is absolutely no advantage for the combination. If we include only patient positively curative situation, possibly curative patient, the combination, I'm convinced if we come back and if we build a new randomized trial, I'm convinced that the combination is superior to monotherapy, even for overall survival. It is my hypothesis, but I think I'm not so far from the situation. So when you give a look to the ESMO recommendation, multi-agent chemotherapy is only is a treatment of choice if the objective when you take a charge of your patient is to obtain the tumor shrinkage or to increase the PFS or overall survival when this chemotherapy is followed by local regional therapies of this, especially for young population, if the performance status is good, and if you can operate or treat locally patient with, for example, oligometastatic patient. I think you remember the beautiful story of olaratumab. It is a recombinant human IgG1 monoclonal antibody that specific target PDGFR alpha, and olaratumab have demonstrated anti-tumor activity alone or in combination with doxo in xenograft models. And I think if you will be in ASCO in 2015, we have seen the results of this phase 1b/2 randomized trial comparing doxorubicin plus olaratumab versus doxorubicin alone. And we were extremely surprised, all the scientific community in the field of sarcoma, by these incredible results. No advantage, no significant advantage for the combination comparing to doxo in the progression-free survival, but with a high significant difference in overall survival. You double the median overall survival with a combination of doxo plus olaratumab. So it was very surprising at that time. I remember I was in the audience. We have never seen that in all previous randomized trial in frontline advanced chemotherapy in advance of tissue sarcoma. And in November 2016, olaratumab received accelerated conditional and full approvals globally based on this overall survival results. The drug was used in more than 40 countries. I remember when we met all the different leaders when we built the new ESMO guidelines 2018, we are more careful. So the sentence is here. Olaratumab is available in some countries, and the results of a subsequent phase 3 trial, it was ongoing at that time, already completed in 2018. So the result was awaited for, and unfortunately, I think you remember this press release, the 18th of January 2019, study did not meet the primary endpoints on overall survival in the full population or in the leiomyosarcoma subpopulation. There is absolutely no difference in overall survival between the two arms. So it was a drama for scientific community, for patient, for physician, for everyone, especially this kind of approval drug before the large use of the drug have a cost for the society. And for those who are present at ASCO 2019, Jaap Verwege was the discussant of the plenary session, and the total financial burden for the society was $1 billion for a drug delivered without evidence of efficacy. Just to remember the design, the classical design, randomization 1-to-1, comparing doxo 75 milligrams per meter square at day 1, plus olaratumab IV injection day 1 and day 8. Same combination with the exception, of course, of olaratumab, placebo day 1 and day 8. I remember some of my patients receiving 1.5 years, day 1 and day 8 injection every 3 weeks. So for patients receiving a placebo was sometimes complex. But it was a design to validate this concept. Of course, it is normal to make a placebo, to propose a placebo. And the result was as followed. no advantage in terms of objective response rate. 14% of objective response rate for doxorubicin, 18.3% for placebo with doxorubicin. So slight increase of tumor response, not significant, in favor of doxo placebo. Same thing for the disease control rate with a combination of complete remission, partial remission, and stable disease. So in the overall population, and also for leiomyosarcoma, even significant for leiomyosarcoma in favor of the placebo arm, with a disease control rate of 82% versus 63%. And just to remember you, the previous randomized phase 1b/2 presented at ASCO 4 years before, the objective response rate was 18.2% for the doxorubicin versus near 12%. And the results, I think you're all aware of this result, was grammatically nihil. No, absolutely no advantage in overall survival for the doxorubicin. You see the two curves exactly the same in all population or in leiomyosarcoma. Same thing for progression-free survival, even a slight increase, significant, in favor of doxo for all population. So the results was totally opposed, in contrast with the previous randomized phase 1/2. So I would like to share with you which parameters can be explained this discrepancy. Baseline pathological characteristic, heterogeneity of lung metastasis, post-discontinuation therapies, pre-treatment anti-cancer therapies, and proof of concept analysis of biomarkers. Just to be critical to when you read a paper, when you read a paper on advanced soft tissue sarcoma, we have to consider all these different items. Give a look to the overall survival curve of the phase 1b/2 randomized trial. You see the split of the curves is very early, not later on. When you see a benefit for a drug, in general, the two curves are similar at the beginning, and after that, after a few weeks or months, you can have a difference in favor of the experimental arm. Here, you see a benefit immediately. It's like if there is two explanations, or so you have a lot of toxic deaths in the control arm, or there are other diseases to explain this kind of split early, without any benefit in terms of progression-free survival. Remember, to give a look to the phase 1b/2 randomized trial. Besides the well-known liposarcoma, leio, UPS, who are the most common histological subtypes included in all different advanced soft tissue sarcoma paper or study, you see here in red and in green some histological subtypes included in this phase 1b/2 randomized trial. So I give you some example in green. Chondrosarcoma of bone. I think you all agree it is not a soft tissue sarcoma. Extraskeletal chondrosarcoma. It's a challenge. In general, it's not accepted in soft tissue sarcoma paper. Soft tissue undifferentiated round cell sarcoma, more like an Ewing extraosseous Ewing sarcoma. Undifferentiated neoplasm. It means it could be maybe not a sarcoma. And give a look on the red part. Alveolar soft part sarcoma. I think you know this 1% of sarcoma. It is an indolent disease. Clear cell sarcoma, it could be related to melanoma. Soft part melanoma, it exactly the same like clear sarcoma. Endometrial stromal sarcoma, there is some indolent diseases. Extraskeletal myxoid chondrosarcoma is also indolent. The fibrosarcoma in a recurrent DFSP is an indolent disease. The globus tumor, maybe not a sarcoma. Solitary fibrous tumor is also an indolent disease, and myxoid chondrosarcoma, same thing. So if you add these different favorable histology, you see here in the doxorubicin arm, 66 patients only. 10 of these have favorable histologies. 15% of all patients included in this arm. In contrast, there is only 3 patients, 4.4% in the doxorubicin arm have this histology. So when you include very few patients, you can include tomatoes and carrots, and the result could be influenced only based on histological subtypes, and I think you are all agree with that. When you give a look in the later randomized phase 3 randomized trial, of course, the most frequent histological subtypes are well balanced, LEO, LiPo, UPS, but also in terms of unique histology, more or less the same histology we have seen before, but they are well balanced. Curiously, 28 patients in the placebo doxorubicin combination have a low grade soft tissue sarcoma, grade 1. In general, we exclude this kind of patient in all randomized trials. We try to include only grade 2 and 3. There are indolent diseases, so you see an imbalance between the previous phase 1b2 randomized trial, more indolent diseases in the olaratumab arm, and maybe here some indolent diseases in the placebo arm. Here you have the natural evolution of advanced soft tissue sarcoma, depending of histology. On the right part, you see liposarcoma and dermatofibrosarcoma. On the left part, you see vascular sarcoma, angiosarcoma, and so on. We are in the field of sarcoma, but you see here, the 5-year overall survival is totally different between histological arms. So the overall survival depend on histological subtypes and could influence results of the trial. And I remember the results of the French sarcoma group published every year. What we do in France when we review the histological subtypes, you remember there is a major discordance in 10% of cases, but there is minor discordance in 20% of cases. Minor means in one center it could be a leiomyosarcoma. When you review the slide, it is a LiPo or vice versa. So there is 20% of minor discordance in histology. So the review of the specimen are very important when you publish the paper. Another items I would like to share with you is a baseline characteristic of patient. As you know, the vast majority of our patients who relapse exclusively on lung metastasis. We have 50%, more than 50% of our patients have isolated, I mean not one nodus, isolated, it's the only site involved by metastasis. And you give a look to the pool analysis of 10 consecutive soft tissue and bone sarcoma group from ERTC, 10 trials, including 580 cases. And you see here the median overall survival only based on the major size of lung metastasis. The median overall survival for patients having metastasis with a size inferior to 20 millimeters, 2 centimeters, is around 20 months, comparing to 10 months when the larger metastasis is superior to 5 centimeters. So you have the same patient, but not the same size. And you double spontaneously or with treatment, but it is a negative prognostic factors to have larger metastases. So when you include patient with lung metastasis, maybe the future will be also to include not only presence or not of lung metastasis, but also the size of the larger one. So you see it's different. It's dramatically different, 10 to 20 months. Same thing for the disease-free interval. When there is, you are all aware on that, more you're an aggressive disease, when the patient relapse 1 year after the localized resection and patient develop metastasis here 1 year after diagnosis, the patient have a poor prognosis comparing the patient relapsing more than 2 years. 10 months, 20 months, exactly the same thing. When you combine these two parameters, you can include patient having with a histological subtype different. You can mix a lot of different patients with totally different behavior. So maybe also in the future we have to include this kind of prognostic factors, not only lung mets, yes, no, but disease-free interval, size of lung mets. Another interesting point, of course, in all randomized trial, when you test an experimental drug in frontline, when the patient progress, you can propose different things, a lot of different things. Approval drug for sarcoma, it is the case for trabectedin, pazopanib, and eribulin, it's like last years. You can use old drug like high-dose ifosfamide, dacarbazine, but a lot of patients, and you know, even I think in Switzerland and in other countries, you use gemcitabine alone or gemcitabine plus dacarbazine, combination of gemcitabine docetaxel, especially in US, other drugs. But sometimes, and you see a lot of patients treated with non-approval drugs, experimental drugs outside any trials, immunotherapy, TKI, some patients receiving 10 consecutive drugs. So you can modify, of course, overall survival with all these drugs. But I would like to focus also on local regional therapies given to the patient or in a context of stabilization with the experimental arm or in case of progression. Local regional therapy. Local regional therapy means surgery, means radiation therapy, stereotaxic radiation therapy, radiofrequency ablation, cryotherapy, whatever. Just give a look to this retrospective French sarcoma group analysis on 213 patients collected in the database from 2000 to 2012. It is not randomized, it's only retrospective analysis, so there is a lot of bias, of course. It's not only to discuss with you, because it's more or less the reality, the real life of our patient. When you treat a patient with systemic treatment alone, I speak about oligometastatic patient. I mean 1 to 5 mets, not only in the lung, 1 to 5 mets. It is what we call oligometastatic patient. If you treat it with systemic treatment alone, you see here the curve of the patient. But if you add a local regional therapy, the patient are here. You modify, okay, there is a large gap between the two curves. The reality is maybe more, it is between. But when you propose a local regional therapy, of course, you increase the disease-free survival between the two consecutive lines, and you can modify overall survival, adding a surgery. It is more or less what I've discussed with you with the Hudson trial in the RTC. When you combine the study palliative patient or palliative or possibly curative patient with oligometastasis, they are not the same patient and not the same diseases. And if you give a look to the publication in general, even in beautiful paper, in the field of soft tissue sarcoma, you mentioned of the other drug, systemic drug, where the patient receive after progression, but very rare. The local regional therapy are rarely mentioned in publication. In the phase 3 of olaratumab, you give a look to these items. Radiation therapy, more than double of patients here in the placebo arm receive a radiation therapy. 70 patients versus 39. I cannot explain that. It's only to show you that only based on the radiation therapy, and radiation therapy means I don't know where the patient, on which localization the radiation was performed, could be in bone metastasis, maybe in the primary for patient having a relapse plus meds, or a radiation therapy on lung meds. I don't know, but there is no difference in terms of other drugs, gemcitabine, trabectedin, pazopanib, olaratumab, even olaratumab here. But the only difference was the radiation therapy. This discrepancy would explain, at least in part, the better rate as the superiority of this arm. You understand what I mean? And when you come back to the previous phase 1-2 randomized trial, local regional therapy was not mentioned at all. Just to focus on an ongoing treatment on the oligometastatic patient, it's an ongoing ERTC trial named OligoRAR. It is to validate this concept, at least prospectively. You treated your patient by a cytotoxic agent, targeted agent, hormonal treatment, immunotherapy, whatever, and you randomize patient between continue the same treatment versus to continue the same treatment plus stereotoxic body radiation therapy. So it is to validate this concept of oligometastatic patient. And I'm sure that this study will be positive, but I anticipate normally you have the same risk that I have present you in the French sarcoma group. You know, there is a paper when you validate retrospectively, when you have an idea based on retrospective analysis, when the retrospective analysis is positive, you validate this concept in 75% of cases. I remember a paper giving this information. So for the young attendees beside their computer, if you have an idea, please, retrospective analysis is very, very fruitful for the future, especially in the field of sarcoma. So when you give a look in the phase 1b/2 randomized trial, you see here any additional treatment without any more information. You have more patients receiving additional treatment in the olaratumab doxorubicin arm comparing to the doxorubicin alone. No other indication. So local regional treatment can heavily influence survival of patients with advanced soft tissue sarcoma, both positively in the phase 1b/2 trial and negatively in the phase 3. This constatation can explain in part the discrepancy between these two trials. When you give a look to the post-treatment anti-cancer therapy, so we speak about now not local regional therapy, but the other drugs. Here in the phase 1-2b randomized trial, the other administered drugs were well balanced between the two arms, with the exception of trabectedin here, 16% in the experimental arm, 4.5% in the doxor arm. Same thing with pazopanib. I don't know if it is significant or not. The question is only to discuss with you. There's more patients receiving active drugs in second, third, fourth, fifth line, and they can influence the result. Of course, here it is only one picture of all the different trial testing trabectedin in advance of the sarcoma. Now we know if we select correctly the patient, you increase the median progression-free survival, and the tumor control at 6 months, and overall survival in the large recent trial. So, of course, it is an active drug, so you can modify overall survival of the patient included in experimental arm. Same thing for pazopanib and TKI in general. You know there is an impact comparing placebo in the palette trial, and if you select also correctly the patient like synovial sarcoma, very sensitive histotype to pazopanib, of course you modify the overall survival in advance of this sarcoma. And give a look, investigational drug. 12% of patients, including the doxo or olaratumab in the phase 1b/2 randomized trial, have receiving an investigational drug. Only 3% in the olaratumab arm. Given that, you can modify the overall survival. I give you just an example of a patient. I see this patient post-doxo EFO. It was a SMARCA of A4 deficient sarcoma. You see here the mass here and here, progressing after doxo EFO. I have included this patient in pembrolizumab treatment in March 2018. 3 years later, it is more or less in complete remission. Of course, you influence overall survival on one patient. It's only to highlight this kind of different discrepancy. You can modify if you find a revolutionary drug like imatinib in ulcerative sarcoma, you modify the overall survival of this patient. Same thing. I give you an example of an epithelioid sarcoma. Normally, it's very aggressive with a tertiary lymphoid structure, more favorable prognostic factor for immunotherapy, and this patient have a tumor control of more than 64 weeks. So, of course, it is case report. It is only to share with you the modification of overall survival. More you give drug to the patient, more you can modify. Same thing for alveolar soft part of sarcoma, totally sensitive of with immunotherapy, 42% of response rate in this little phase 2 trial. And I remember there is 2 alveolar soft parts sarcoma in the olaratumab arm. I'm convinced that these 2 patients have not received immunotherapy because it was before era. But today, if we include this kind of patient, you can modify the behavior of this alveolar soft part sarcoma, of course. And of course, we are aware of that. If you have the chance to find NTRK fusion gene, you modify the overall survival of this patient. The other intriguing things is not the post-treatment, it's the pre-treatment. Normally, I don't know what is your agents you use in frontline chemotherapy regimen in advance of this sarcoma, but in general, the first line is more or less doxorubicin or doxorubicin in combination. Here in this study, in the last phase 3 randomized trial, 75% have not received any treatment before. It means there's 25% of anthracycline naive patients receiving another systemic agent before doxorubicin regimen. It was unusual. In general, it's at 25% of of chemotherapy naive patients have received another drug like anthracycline to be included in this trial. Of course, they have not received doxorubicin in front lines, 25%. And I give you only an example of a drug modifies the overall survival. If you give, for example, in front line to an epithelioid sarcoma, tamezetostat, ZH2 inhibitors in SMARCB1 deficient soft epithelial sarcoma, you can modify also before the experimental drug. You select a patient with unusual tumor control before any inclusion in an experimental arm. And just to share with you, there is 3 epithelioid sarcoma in the phase 1B and was all in the olaratumab arm. Also, again, I'm convinced that these 3 patients have not received the ZH2 inhibitor before oladoxo. But it's only to share with you all the different, in little phase 1B2, 66%, 66 patients per arm is a too small number of patients to be conclusive. But I think the most important things is a proof of concept. If you test the drug, you have to have a target. And olaratumab was developed to be a monoclonal antibody against PDGFR alpha. And you know that in the advanced soft tissue sarcoma, around 1/3 of advanced soft tissue sarcoma overexpress PDGFR alpha. In the phase 1B2 randomized trial, there is absolutely no interaction between PDGFR expression, positive or negative, and treatment. So even in the previous one, when you see the difference on overall survival, they are not explained by the target. So it's a complex situation. You give an antibodies against a target, but the target have no impact if you express or not express. So in the phase 3 randomized trial, they give a look to the PDGFR expression or not. When you have a positivity of PDGFR alpha, maybe it is a poor prognostic for soft tissue sarcoma, but whatever the treatment, make doxo alone, or doxo placebo, or doxo plus olaratumab, give more or less 18 months of median overall survival. And in case of negativity, so no expression of PDGFR alpha, 22, 23 months of median overall survival. You have the curve here. So there is no impact on treatment. Complex situation for an antibodies against this target. So I like this sentence from Paolo Casali: targets have to be targeted, but sometimes tumor cells do not understand what human beings are doing. In the proof of concept in mesenchymal tumor, especially in the field of PDGFR, here you have a target, but you have a mutated target. In the GIST, 8%, 10% of all GIST have a mutated target, mutated PDGFR. It is the reason why imatinib or avapritinib or whatever TKIs have an effect, because it is the initial event activated mutation. It's not an overexpression of the protein. It is a gene alteration, and maybe the initial cause of this disease. Same thing for dermatofibrosarcoma protuberance. With the translocation 1722, there is a loop, an autocrine loop, amplifying the PDGFR. And imatinib, you know, it's an anti-PDGFR. So these 2 targets are or alterated or amplified, which is the reason why the drug, an anti-PDGFR, is active. It's another story, but it's also sometimes the drug is good, but the doctor is maybe not so good. Here you have the story of aldoxorubicin. Maybe some of you remember this story. I were in ASCO in 2014 with this aldoxorubicin. It is doxorubicin with a link fixed to the albumin, less toxicity than doxorubicin, no alopecia, no cardiac toxicity. Little phase 2, 126 patients. Favorable issue in favor of aldoxorubicin, significant for PFS, comparing to doxorubicin alone. I remember in 2014, yeah, we have maybe a new drugs in doxorubicin. And I don't know why the phase 3 has not validated this concept. The design of the study was not aldoxorubicin versus doxorubicin in frontline, but aldoxorubicin versus investigator choice, and not only in frontline, in all lines. I remember the country or the sites, the center have to choose between 3 different options, dacarbazine, pazopanib, or gemdocetaxel, or even doxorubicin. So it was a mix of different things. In the study, the slightly non-significant in favor of aldoxorubicin, but the drug was dead. No, it's impossible after this kind of results to commercialize the drug. So the drug is good, but sometimes the scientific committee who developed the design, when you find something in the phase 2, you have to validate the concept in phase 3. Other interesting concept, it's only provocative, but you remember the story of gemcitabine docetaxel. I am an old scientific specialist on sarcoma, and I remember I was in the ERTC 30 years ago, 25 years ago with Jaap Verwij. We have tested, Jean-Yves Blais also remember, we have tested docetaxel in advance of this sarcoma. 40 patients, 0% of response. 10 years later, Hensler and colleagues report a dramatic activity of the combination of gemcitabine docetaxel in uterine leiomyosarcoma, but also in leiomyosarcoma in general. And US push this combination. A lot of centers, even in France, even in worldwide, use Gemtax in frontline chemotherapy regimen. I see a lot of patients outside referral center receiving Gemtax in frontline. So we designed, Beatrice Seddon designed in UK the randomized trial. Gemtax versus doxorubicin, it was exactly the same results, even in favor of doxo in terms of toxicity, if I remember correctly the paper. So again, it is academic trial, of course. When you mention an activity in phase 2, when you select good candidates to receive a new combination, of course, you increase the objective response rate, you increase the PFS and overall survival. And then when you try to include all the patients arriving in referral centers, the truth is totally different. So there is absolutely no advantage for the combination. You see here the 5 randomized trial, more recent one, comparing doxo versus another drug versus a combination. The Hudson trial, doxo versus doxo plus CIFO, Picasso 3, doxo versus doxo plus a little sister of ifosfamide, the palifosamide, no toxicity, the new ifosfamide with less toxicity of bladder and neurotoxicity. Already seen doxo versus docetaxel gemcitabine, doxo versus plus evofosfamide, and the last one with loritumab. Absolutely no difference in median overall survival in favor on experimental arm. Interestingly, the median overall survival increased over the time, but even also the control arm here from 13 to 14 months in 2014 to 20 months in the last one. So we make progress, of course, but the control arm performed better than expected was one of the explanations of the non-significant difference between the two arms. Is not related to this item. It is, in general, we increase the median overall survival of our patient, of course, due to the drugs, of course, due to the approval of ifosfamide in 1984, trabectedin in 2007, pazopanib in 2012, eribulin in 2014, and retrospectively we increase the median overall survival. But it's very complex in advanced soft tissue sarcoma to find a drug who improve per se overall survival. You increase PFS, but you know today that there is no approval drug by FDA or by EMA only on PFS, with the exception of GIST in the field of mesenchymal tumor. But in the field of soft tissue sarcoma, it's complex. And I finished my talk on not only on front line, but also on second line here, or second line or more. In pretreated soft tissue sarcoma, here you have the 4 randomized, larger randomized trial comparing pazopanib versus placebo here, eribulin versus dacarbazine here, trabectedin 2 different schedule here, and trabectedin versus dacarbazine here. Give a look at the median overall survival. More or less 2 months benefit, 2 months benefit, 2 months benefit. One time, the 2 months benefit is not significant. For the other, eribulin, dacarbazine, same number of patients, more or less the same, not more or less, we are in the same situation, second, third, fourth line. 2 months benefit, significant. Trabectedin versus trabectedin, 2 different schedules. 2 months, not significant. Of course, here, not significant. So, with the exception, why? I'm not a statistician, so it's, of course, it's a question of power. But it's surprising for one study negative, one study positive. Even for eribulin, it's only, I know for liposarcoma, it's an active drug. In this trial, we included LEIO and lipo all together. And you see here, eribulin versus dacarbazine, absolutely no difference in PFS. With the translation, the positive translation for eribulin, 2 months more. 2 months for a patient is already significant. Huh? I remember here we make a test, a questionnaire for the patient. For a patient, if you increase the overall survival, how can you explain in duration of day or weeks for you what is the significance of benefit? For the patient, the response is 3 days. For advanced situation, 3 days more for a patient is significant. So 2 months is a positive issue, but how we can understand no benefit in PFS like olaratumab, positively translation in overall survival. Just only to push you to give a look to the pre-treatment, post-treatment characteristic of patient. Eribulin is an active drug, it's not the way to discuss. But when you give here a look in the post-treatment, after failure to eribulin or dacarbazine here, 34 patients received doxorubicin after eribulin, and only 77.1%, half of them. I'm not tell you that it is due to the doxorubicin. It can explain the 2 months. It's only to share with you. Doxorubicin is active also after second, third line, fourth line. So would explain in parts. It's only to share, to discuss with you. And Bruno Fuchs gave me this paper last week. I like this. I advise to you to read this paper, An Urgent Call to Raise the Bar in Oncology, Transformation of Medical in Education, Improving Clinical Trials, Quality, Conduct of Reporting, Strict Adherence to Scientific Norms by Regulatory Agency and use of value-based scales can contribute to raising the bar for oncology drug approvals and influence drug pricing and availability. So I would like to thank who heard me on this topic. I hope you enjoy. So of course, I'm ready to try to answer to your question. Thank you. Hello, hello.
Professor Fuchs, I believe we cannot hear you. You would have to unmute yourself. Thank you.
Sorry about that. Axel, you really have to be congratulated for an excellent job. You surgically dissected the sarcoma oncology literature and were really thought provocative. And let's say in this context, I first want to urge the audience to put the questions into the box. You also can join the panel. Just let us know. But in the meantime, I would like to ask Jean-Yves to give an appreciation of, let's say, Axel's thoughts and his provocative analysis.
Can you hear me?
Yes, we hear you well.
Yeah. So what Axel nicely, really nicely showed in a historical perspective is, I think, two things. The first one is that we used to be agnostic. It's very popular to have histo-agnostic approaches in cancer based on molecular analysis. But in sarcoma, where there are more than 100 histological subtypes, we are histo-agnostic, and we are moving towards non-histoagnostic treatment in first line based on a more in-depth understanding of the biology of the tumor. We have discussed a lot of randomized clinical trial within Axel presentation. Probably in the future, we will be in difficulty to generate these clinical trials as a population that we are going to study narrow down, and probably a signal of activity and single arm will be much more important. But that's a major conceptual change for us and as well for the health authorities. I think, but the fragmentation of the disease landscape in sarcoma, including in first line, in particular in first line treatment, is something which is going to completely change the way we treat patients in the future. That's very challenging for this group of rare tumors. Another thing which is very important, Axel insisted a lot on that, is that we need to base our clinical trials on a good biological rationale. If we don't, or if the rationale is weak, we may fail sometimes to generate something which is meaningful or not confirm phase 3. And sarcoma is absolutely loaded with histories of randomized phase 2 or phase 2 very interesting, and phase 3 not confirming. It should be studied, by the way, as a topic by itself, because the number of trials like that is very impressive. But I think that's really something which comes to mind. And at the end of the day, it's personalized treatment that we are speaking about. Personalized for all sarcoma, and 100 sarcoma means 100 personalized treatment. At the end of the day, that will be it, probably more. Thank you, Axel. Remarkable presentation.
Thank you.
In this context, I would like to ask you, how do we get there? I mean, you nicely showed, let's say, with the, olaratumab and, what, let's say, missing information we include, and we are not considering them. Meaning, if we further dissect our patient cohort for such a study, obviously the groups become even smaller, meaning the urge, let's say, to collaborate and share is even bigger. And having you here as, let's say, the key proponents of the World Sarcoma networks and clinical trials, how does these thoughts influence, let's say, the guidance on this level? Maybe to you both.
Axel?
Yeah. When you see, when I speak of in my talk, I insist on the local regional therapy. When a patient became metastatic, the patient are given to, in general, medical oncologists, and medical oncologists try different agents, and we have to rediscuss this patient even in metastatic situation. We are surgeon, we are radiotherapists, so it is important to discuss in multidisciplinary team also metastatic patient. We increase overall survival or PFS with local regional therapy. So local disease is belong not to the surgeon, and advanced disease not belong only to medical oncologists. It is a mix of different specialty, and when we build a new protocol, even in advanced disease, we have to notify the local regional treatment, never collect prospectively, or they can influence our survival patients. So we have to reconsider some randomized trial based also on local regional therapy, surgery, radiation therapy, and so on.
I think in addition to that, the value of working together it used to be nice to work together. Now it's absolutely mandatory. I think when Jaap Verweij and George Dimitri generated the World Sarcoma Network, the ambition was extremely simple: informal discussion across groups. Let's share the work. At this time, there were probably 50 or something like that histological subtypes well characterized. Now we have more than 150. We do not have enough groups around this planet to do the work. So we need to work together to split the work across groups, each taking one, because this has too much work. Well, you see, when we looked at the number of trials per histotypes in the recent publication that we did in our 10-year experience on histological review, it's dramatic. Actually, most sarcoma subtypes did not ever add a clinical trial, ever. So we base our decision on the whole sarcoma as a group. That cannot continue like that. So we need to split the work, and we definitely need to work together. Probably Europe is a very nice place for that, because we all are very much the same across country. We have different systems, but we are very much the same. And what we need to do is collaborate, clearly.
Very nice, thanks so much. There are obviously some questions from the audience, and we just go through them. The first one is, what is the value of pulmonary resection for isolated single multiple pulmonary metastases, and the role of adjuvant neoadjuvant therapy in this situation? Maybe just do both. Axel, want to start? And
you see, I'm convinced on the local regional therapy. There is no randomized trial comparing surgery of lung mets versus stereotactic radiation therapy. I don't know if it is better for the patient to be operated or not. It could be an academic trial. For oligometastatic patient, you randomize patient between surgery and radiation therapy versus radiation therapy. It's a very complex trial. I remember even for ERTC, for patient with only isolated lung metastasis, we try to build a randomized trial comparing neoadjuvant chemotherapy followed by surgery versus upfront surgery. And the study was closed for inclusion due to vast majority of patients refused to be randomized. When you have in the run, it's easy to compare Coca-Cola versus Pepsi-Cola in terms of systemic agent, very easy. But two strategy, very complex. When you have surgery versus no surgery, all patients refuse. Surgery, not so an important sentence for a patient. So today we have a lot of discussion in each board. We have no the truth. I don't know if we have to add adjuvant or neoadjuvant chemotherapy besides the surgery of metastasis. It is a burning question, remaining burning question. If the patient, my answer will be different. If the patient not receive doxorubicin for anthracycline chemotherapy regimen for the localized disease in neoadjuvant or in adjuvant situation after resection of the primary, and the patient relapse with lung mets, I'll be in favor. It is a recommendation also for ESMO guidelines to propose chemotherapy in metastatic relapse before or after resection of chemotherapy, with the exception of one lung mets operated or treated, you can avoid chemotherapy. But in general, if the patient received prior chemotherapy for localized disease, which is more or less the same chemotherapy for in frontline for metastatic patients, so you have already used doxorubicin, there is really no indication to besides the surgery of lung mets to add again chemotherapy.
Jean-Yves?
I think the only thing I would add, I completely agree. The only thing I would add is that it's difficult to do some randomized trials, but sometimes you also see that 20 years afterwards it's becoming possible. We did that with retroperitoneal sarcoma study with radiotherapy, so we may try again. But I think actually is right. We have to be pragmatic on this one. One number which always strikes me, and which is true across all large series, is that you take a metastatic soft tissue sarcoma. If you get a complete remission, you have about 20% of the patient in complete remission alive, progression-free at 5 years. So it's not a randomized study, of course, but that's large series which are very, very consistent, whatever the way you get to complete remission. So thinking about complete remission, you must think on how to get to complete remission, and surgery is a key factor for small number of mets, admittedly, less than 5.
Let's go to the next, specific question. What is the value of surgery for primary cardiac sarcomas and systemic chemotherapy? We discussed such a case. It's your case, actually, Jean-Yves, on May 20th. Maybe you want to summarize again?
Well, I can comment. The patient is doing well still, by the way.
Yeah.
with only brain mets. I think the retrospective study, which was done by Nicolas Isambert, I think some 6 years ago, was surgery is always better than no surgery, and chemo is always better than no chemo. But transplantation, the series are really small. There is one small series, if I remember correctly, of less than 10 sarcoma.
And non-angiosarcoma are always better than angiosarcoma.
Oh yeah, sarcoma are the worst. Yeah.
Okay, then a general question. Someone is interested in combination therapy with checkpoint inhibitors and TKIs.
Checkpoint inhibitor plus TKIs. Yeah. I don't know if there is ongoing trial with these two totally different approach. Maybe in some country with ongoing trial, but I'm not aware on the combination of pembrolizumab or pazopanib or whatever. I'm not.
There are single-arm studies still ongoing, but randomized comparison, not to my knowledge, indeed.
No.
We may miss some trials.
Then another question is the role for neoadjuvant therapy, chemo, radiation. What is the role in the neoadjuvant setting?
Of course, it is totally open for discussion. There is some country where there is some study, retrospective study, or maybe ongoing study with a combination of doxorubicin plus the concomitant chemoradiation therapy or sequential chemoradiation therapy or alternative before surgery. It is here, it is our favorite option for young population. We try to give only doxorubicin, and we switch to radiation therapy on before surgery only in case of tumor progression. I know that the Italian center are more in favor to the combination. In US there is some sequential combination. It's very, even when you read a paper, it is always phase 2 monocentric study. So the feasibility is good. We don't have the definitive answer. What is the best option in neoadjuvant situation, having in mind that the patient has to be alive before surgery to try to cure the patient by surgery. The patient are the localized disease are cured by surgery. So you can test a lot of things before, but remember that surgery is the only curative approach.
Jean-Yves, or let's say, is there any specific thoughts for the retroperitoneal sarcoma in this context? Or I think the general comment.
Well, pre-op radiotherapy failed to be superior, even though you can discuss on subgroup analysis. I think it's still subgroup analysis, hypothesis generation only. We are randomizing neoadjuvant chemo. I think it's complicated. It's also complicated to select the patients, I must say, because many patients are not that localized, actually, which is an interesting question, by the way. I think that's one of the area where you still need a randomized. You will still need a randomized study, even though it's rare, because anatomical location is crucial here for this question. But so far, surgery only remains the standard, I guess, unless.
Another question refers to if we like to design a randomized trial in first-line setting, which is the ideal standard of care, doxo or doxo-ifos? And which subtypes should be excluded?
It is only a question of selection of patient. If we have in palliative, totally palliative situation, it is doxo alone. Palliative means liver plus lung, bone plus liver, 3 sides, 2 sides. We are in palliative situation. So in this population, doxo remains standard. In non-selected histological subtype, and for patient with potentially curative situation with lung mets, is doxo-ifo.
And I young think patients.
In young patients. And we have to avoid also to include patients with rare soft tissue sarcoma histotype, where other drugs are available, where there is target only patient with LEIO, lipo, UPS, even angiosarcoma. Really, for me, the best agent is viclitaxel, even in neoadjuvant situation. I do it frequently in neoadjuvant situation or before sarcoma of the breast. Incredible response. So if you use doxo plus ifo is for synovial-sarcoma, UPS, LEIO-lipo, and MPNST. The others are so rare, so we have to exclude all these other, more or less the same histological subtypes of the bronchi study, the more frequent one. But the best thing is maybe in the future is to design a randomized trial in only one histological subtype. In LEIO, for example, and you ask a question of, for example, doxo trabectedin versus doxo. It is a case in uterine leiomyosarcoma. It just finished, and the paper was published in next ASCO, next ESMO. Doxo trabectedin versus doxo alone in uterine leiomyosarcoma. So one side one histotype.
So again, it's not going to be any more one-size-fits-all approach, even though it used to be histoagnostic. It's going to vary vary a lot across histological subtypes. So the answer to this question is not that easier than 10 years ago.
So let's say this addresses all the questions we had from the audience. And coming back to your last slide, raising the bar. Any additional comments apart from what you now shared with us? How do we raise the bar? How do we avoid, let's say, having being the situation in 10 years again to say, no, it did not change? So how can we change this?
Working together, all together. That's the only way.
And you think just meetings and having fun, or?
No, doing clinical trials at the global level.
Yeah. Do you see any
and to have this systematic approach, and you take that, you do the job on this one, we will join. You take the job on this one, we will join, and so on and so on.
Totally agree.
Awesome. I think this addresses all. I see that there's still more than 60 participants are still among us. That's very fantastic. I think the value of these discussions are also really excellent, and thanks to the excellent talk that you gave, it's really thought-provoking. I think this is just very nice. I thank you, Axel, and Jean-Yves for your contributions, that you share your experience with all of us. I think that's just awesome. And as you say, through this, we can raise the bar. We will have our next multidisciplinary case discussion in 3 weeks. You will receive announcement again. In this context, before I hand over to Charlotte, I would like also again our sponsors, Foremost PharmaMar, who makes this all possible. It's really something we appreciate very much. So thank you very much. See you in 3 weeks. And Charlotte, please.